We have Sarah Hyde-Williams. We're so excited she's here. She's an elder care consultant and dementia educator trainer at Senior Living Advisors of Austin, which is an elder care advisory service guiding families in finding care for an aging loved one through advanced care planning, senior housing placement, consulting, education, and support. Thank you so much for being with us today, Sarah.
Absolutely. Thank you for having me.
Go ahead and get started if you want to share your screen.
Eden, I think we lost you.
Oh, okay. I was going to say we can go ahead and get started if you want to share your screen. Can you hear me?
Absolutely. All right. Really cool. We have people here from all over the nation. I see a couple of Sun City folks. That's in my neck of the woods, here just north of Boston. So let me get these slides up. Let's see, the button didn't push. There you go. Thank you, Eden, for that introduction. I am an elder care consultant. I do a tremendous amount of living options, care planning, and caregiver support. So lots of letters behind my name that just means that I am really serious about educating myself on what does aging look like, what specifically does dementia look like? And as it relates to the Parkinson's and Movement Disorders Alliance, my specialty happens to be in those synucleinopathies of Parkinson's, atypical Parkinson's, dementia with Lewy bodies, and Parkinson's disease dementia. So that's the tremendous amount of work that we do here in our company, talking families through care planning, A through Z. What does that conversation look like? What are all the items that we need to consider when we begin having that conversation to at least have a framework of what that care needs to look like in our future? What is our plan A? Let's plan for the worst, hope for the best. And so we want to at least have a framework of that set out, legal, financial, what does care look like, all of that, so that our loved ones can take that information and run with it in case they need to. So I am going to move my screen there because I can't see all my words. There you go. All right. Why plan for care? Why even have this conversation? Why even think about it in the first place? Why have the conversation with our loved ones, whether it be adult children, whether it be spouses, siblings, maybe parents that we are stepping in and trying to help do some planning for and with. So first, you have time to explore all of your options. Time is really important because when we are making decisions on the fly, oftentimes those decisions are not what we would choose for them to be. So we have time to think through all of this, like mull it over in our mind or make financial or legal decisions moving forward that can really affect what that care might look like and how we pay for it. Where might we have that care delivered? So we have time to explore all of that and really think it through, maybe even change our mind on a few things. We also have control over the choices that are made. So many times I speak with families and we have not talked through planning for care, specifically as it comes to a specific diagnosis or something that may be acute or chronic health conditions that pop up. When we're making those decisions in an emergency place, let's say we've gone to the hospital and we need to make those decisions very, very quickly. Oftentimes, if we've not done that pre-planning, a lot of our choices are taken off the table. In an emergency situation, oftentimes our choices are incredibly limited. So we want that time to be able to have the choices that we want because we've thought that through. We relieve our family of the burden of making those decisions. Really quick story. When my husband and I were dating over 10 years ago, he went in for knee replacement surgery. It was just supposed to be, let's clean it all up, patch him up, and get him right back out the door. About 10, 15 minutes into that surgery, remember, I wasn't his wife yet. The surgeon comes out to me and said, "It's worse than we thought. Do you want to do a total knee replacement?" I didn't know. We hadn't talked it through. And so what a burden on me, wondering if I even made the right decision. Hopefully, that would be the right decision when he got out of surgery, and he would be okay with that decision. Hope he was. But it is a big burden when our families are thrust into making those decisions that they do not know what our choices would be. We've not talked it through. So we really want our loved ones in that type of situation to know what our choices are and to be able to simply walk through those decisions that we made for ourselves. Then we have time to assess our entire financial and legal situation, along with document the care that we want. When that is documented, when we have everything in place, we've made the financial arrangements, all the legal documents are put in order, and we have documented what those choices are, then our family can simply take those decisions that we've made and they can execute upon that. So we have time in which to do that. So that's why we plan. It's incredibly important that we have these conversations now so that we have time to think that through. So we're going to talk through care planning. What does that look like? We're going to start at A. We're not going to hit all 26 letters of the alphabet, but we are going to end up at Z. So if you'll bear with me, we're going to hit some highlights of A to Z. And if you have some questions, I'd be happy to take those. Let's save those until the end, or even interrupt me if I miss something, or if you want to write something down. Absolutely, we'd be happy to go over those. So let's start with A, acknowledge. We want to acknowledge that planning needs to happen. So we need to think through, yes, that planning needs to happen and happen now. AARP did a study a couple of years ago, and that was determined that 90% of us know that it should be done. Only 27% of us actually do that planning. So can you imagine all the people that don't do that planning, and how stressful that would be on the entire situation when that planning is not done? So acknowledging that it needs to be done, beginning to think through, how do those choices affect me? And if I am relying upon someone around me to be a part of those decisions that I make, how does it affect them? Acknowledging and having the conversation of how it affects me and affects them. Also acknowledging the reality of our decisions on others. So if we're asking them to be a part of that, absolutely, we need to talk that through and have them be part of those discussions. I'm going to twist it for a little bit and say that in some instances, let's say the care planning is not for us. It is that we've acknowledged that care planning needs to happen for someone else. Oftentimes, adult children are stepping into a situation which for our parents, we need to have those conversations. So in that instance, A would be for ask. Ask the right questions. Say, hey, mom or dad, I need your help with something. I was thinking about, and bring the topic up. At least they know that you are open to having that conversation, and that it opens up the lines of communication for us to be able to talk that through. So A for acknowledge. C is for care. What does care look like? What is care? And so let's it's kind of an onion that let's tear that apart for just a second. Care is oftentimes in the medical world defined oftentimes as IADLs or ADLs. And if you're not familiar with the term, let me sound them out for you. ADLs are activities of daily living. Oftentimes I draw a bullseye for families, and that's that inner core of that bullseye. ADLs. So those are bathing, dressing and grooming, toileting, eating independently, and transfers. Every now and then, a long-term care policy will throw in as a sixth ADL medication management. But now we're going to talk about IADLs. So those are instrumental activities of daily living. So if our ADLs are that center of the bullseye, go out a loop. Those are IADLs. So in that case, that is managing your budget and your finances. That is transportation to all the places you need to go. Shopping, let's say getting groceries, buying clothing, picking up your medications from Walgreens or CVS. That's keeping a calendar, that reminder of all those doctor's appointments or when to pick up meds, other appointments that we've got. That could be meal preparation, planning a meal, putting that meal on the table, getting it cleaned back up. It could be housekeeping or laundry or pet care. Oftentimes we think of that as extracurricular activities such as hobbies. So all of those are instrumental activities of daily living. And as we begin to look at those items in our everyday life that need attention, let's say we can no longer do those for ourselves, or we just need a little bit of support, we start from the outside in. We start with those IADLs, those instrumental activities of daily living. And then as that progresses, those folks around us are helping more and more and more. Now we're beginning to have some care needs as it relates to the center of that. So we're going to talk in a little bit about where that care could be delivered. But there are other services that might fall into where that care is, it's a service, not necessarily a place. So that could be home care service, or what we oftentimes call as personal assistant service. That is helping with those IADLs and ADLs, someone coming into our environment and performing those with us. That is typically private pay or VA or long-term care policies, somehow, some way that is paid for under one of those items. Medicaid oftentimes comes into that as well. They do have a home care provision. Oftentimes we talk about home health, and home health is a provision under Medicare and private insurance that provides a nurse, physical therapy, occupational therapy, speech therapy, and sometimes a home health aide to help us bathe. That is paid for typically under Medicare or private insurance, VA benefits, and oftentimes under Medicaid as well. And then we have hospice. Hospice is a service, not a place. There are inpatient hospice units. Now, those are for that last few days to a week in life, but typically hospice comes to you wherever you call home. And those are those supports of a chaplain, a nurse, an aide to help you bathe, a social worker, all of the supports as we near the end of life. So that is care in a nutshell. I said that's an onion to be peeled back, but that is a huge piece of what we talk about in care planning of what is that care, what are needs, what needs do we have as it relates to care, and then what are our wants and wishes as it relates to that care. Now we're going to talk through finances. Finances is a huge piece of this as well, because now we've determined there is a need for care and what those wants and wishes are as it relates to care. How are we going to pay for it? So what is my ability to pay for the options that I want? So are there assets that we have, bank account? Is there a long-term care policy? Are there annuities or IRA, stocks and bonds? Great conversation to have with your financial advisor of if we don't currently have those in place, what can we put in place that will help us with this? There are long-term care insurance, like we talked about. And then part of this, if we recognize that our finances are not where they need to be, what should be a big discussion in this would be Medicaid planning. Medicaid is administered by the states, and so it's going to look different in every one of the states across the nation. It will look different in other nations as well. So to have a really good conversation with an elder care attorney on what does Medicaid planning look like. So now we've determined on how that's going to be paid for. Let's back up and talk about housing. We'll get to housing, but we want to know that whatever Medicaid pays for, what does that look like as it relates to housing? And am I okay with that environment, or do we find another way in which to pay for it? So really good discussion should be around our finances about how we pay for that care. Do we have enough assets and resources in which to pay for it, or are we relying upon, let's say, family to step up and provide funding for that as well, or are we relying upon Medicaid? There is VA funding before I move on. There is VA funding as well. There is a provision, it's a pension program under the VA called aid and attendance benefits. If you're not familiar with that, you can always reach out to me, or you can reach out to an elder care attorney in your area, maybe even the VA, and ask those questions about how you might qualify for that and how you might get that pension program enacted. There are VA funded retirement homes. And so knowing where those are around the nation might also be of help to you as we begin not only looking at housing, but how do we pay for it? All right. And now we're going to get to housing options. So now that we've determined the need, oftentimes we need to look at housing options, and given the finances of how do we pay for that, are we going to stay at home? Are we going to move in with a loved one, let's say an adult child or another relative that we've got, or are they going to move in with us? Or are we going to look at a senior living option everywhere from 55 plus through dementia care and even skilled nursing? What does that look like? What segment of each of those will that account for? Whether it's just an apartment, whether it's an apartment with all those IADLs that we talked about earlier, or truly is it there we're doing ADLs and we're looking at assisted living, dementia care, or even skilled nursing if we need that type of care as well. So it's a tremendous amount of what we do in our agency is living options, talking that through. How much does it cost? Realistically, can I afford to live in my home and bring care to me? Or in some instances, that scale tips. And where is it actually cheaper or a more budget-friendly option to go into a senior living community? It's all dependent on wants and wishes and how do we pay for it? So big conversation in that. Part of this is also legal. We should have a legal conversation. Do we have our documents in order that in case we cannot make decisions for ourselves, that someone else can step into that situation and make the decisions for us and with us? I get an awful lot of questions regarding, should I seek a power of attorney or should I get guardianship? So those are two separate things. Powers of attorney can look a couple of different ways. There is a durable power of attorney that allows folks to step into a situation and make legal decisions for us and with us. There is a medical power of attorney that allows others to make medical decisions for us, including where we live. And then this is oftentimes not talked about, but especially in the work that we do, to where there is a mood dysfunction piece, oftentimes misunderstood as a mental health issue. There is a mental health power of attorney as well. I highly advise you, even if there is no history of mental health challenges, go ahead and get one. So just in case that presents itself, We need to, for safety measures of some semblance, we need to enter a psychiatric hospital or some piece of that needs that mental health power of attorney. We have that as well. So powers of attorney are different than guardianship, in which powers of attorney allow someone to make those decisions for us and with us. We still maintain our autonomy in which to make those decisions for ourselves when we can. Guardianship is when the right to make those decisions for ourselves is given into the hands of another. So whether or not that's a relative, whether or not that's an attorney or an aging life care professional, whether it's a guardian ad litem, someone appointed by the court, those are very different. Oftentimes guardianship is difficult to get, it's time consuming, and it is very expensive. So couple of different ways that we could go down that rabbit hole. An elder care attorney can talk us through that, or an aging life care professional. If you're not familiar with those, they used to be known as geriatric care managers, and they can help walk you through that as well. So a living trust is an important document to have. Assets that are managed if and when we cannot. So trusts can become valuable pieces of that legal discussion. Advance directives and a living will. So oftentimes, do we want to be kept alive in certain situations or under certain medical procedures? We can decide for ourselves what that looks like. So those are legal decisions to be made for our care in case we cannot make those decisions for us. One of the things that oftentimes people are not familiar with is a POLST, P-O-L-S-T. This is different in every state. It may sound different in different states, but here in Texas, they are physician orders for life-sustaining treatment. This is an actual order written by your medical professional that says these are the wants and wishes that have been decided upon. These decisions cannot, under any circumstances, be changed. Oftentimes important to have, or at least have the conversation, do I need a POLST in addition to an advance directive? So, and then a will. A testament of how your monies and assets will be divided upon death. So there is a executor of the will, and then there are beneficiaries of that will. And so those folks will need to be decided in that will as well. So good legal conversations to be had with an elder care consultant. If you'll put in the search bar in Google, we all seem to use Google or Bing or one of the others, type in elder care consultant and the city that you live in, and a few will pop up and you begin making some phone calls. Is this the right person for me? So go in and speak with them about what are all these legal documents that I need, what makes the most sense. They also do a tremendous amount of Medicaid planning as well, what that needs to look like. So we're going to skip a couple of letters here and go to P, physical and cognitive well-being. So are there diagnoses that we need to consider when we plan for our care? Are there acute conditions that need immediate attention? Are there chronic health conditions? And especially with PMDA, an awful lot of that would be that Parkinson's piece. So given Parkinson's disease, atypical Parkinson's, dementia with Lewy bodies, whatever that looks like for you, given what a really good conversation with our medical provider, what can I expect? What can I look to the future for in planning those needs that maybe I haven't anticipated? So oftentimes those conversations for me center around a complete medical history. What are those medical diagnoses? What are all the medications that you're taking? What are all your options that could come in the future as opposed to an injectable over a long-lasting dopa drug, all of those. And so we want to plan for that. Certain medications may exclude us from our housing options. Specifically in the state of Texas, there are certain things that assisted living and dementia care communities can do, and certain ones they can't, that would necessitate a skilled nursing stay. So we might want to talk through, what does that diagnosis look like? Medications, how do I plan for the care as it relates to my diagnosis? T is for tribe. And I know this is an interesting word. And the reason I choose this word is because who is your tribe around you? Who are those people in your life that if and when I need something, I can reach out and ask for it? Are they paid? Are they unpaid? Is it oftentimes friends, family, neighbors, other folks that sit on the pew with you at church? Who are these folks that in a pinch you can call and you can say, hey, next time you're at the grocery store, can you pick me up eggs, bread, and milk? What about that neighbor that has stepped in to do a welfare check once a day, just to make sure everything's okay? Who are those other people that we count on, let's say moving in with an adult child or someone else that we've counted on in this conversation to help us with care? Those conversations need to happen. Would you be willing to? And have the conversation of, will you step in? May I ask for this type of care? Who's going to refill all my prescriptions? Who's going to take me to the doctor's office? Who's going to come over in the middle of the night if something happens and I need some help with something? Those types of conversations. Who is your tribe around you that you can count on? Who you might also count on as your tribe would be paid services. Home care that we talked about a little earlier, that becomes part of my care plan as well. Those folks, I know I can count on them when I need them. Let's say Sally can't make it tomorrow, but Kimberly can. So I know that someone's always going to show up when I need that care provided. So who is your tribe around you? And we need to begin plunking that down on our plan. This is who I'm going to call in this instance. Okay. And then we get to Z. Zero. There's nothing else to do, right? We've allotted for all those conversations that need to be had. So there's nothing else to do. Or is there? Really what I advise families to do, and when I have sessions of care planning with families, is that I follow up with a written document. The value is not in the document. The value is in the conversation about identifying those care needs and the tribe around us. Do I need to make an appointment with my financial advisor? Do I need to make an appointment with an elder care attorney? But what we're doing is we're documenting in a document form, what are all those decisions that I've thought through? What is my plan A? What is my plan B? What is my plan C? Putting that in writing, printing that out, and putting it in a notebook of all the rest of your important documents, your financial, your legal, your list of medications, your list of medical diagnoses. Oftentimes I tell families, keep it by the front door or by the telephone. And if an emergency happens, you pick up your notebook and you're off to where you need to go. Doctor's appointment, ER, anything of that sort. You've got those papers ready in front of you that in case decisions need to be made, it's already documented. We've thought it through. Those are thoughtful decisions. Every piece of documentation is done, and our family members simply need to walk through the plan that we've made. So I always advise folks to document in writing what that looks like, print it out, and make it accessible to those around us. All right. The more time you spend contemplating what you should have done, you lose valuable time planning what you can and will do. An awful lot of us say we should do that. We'll get to that. We'll have those conversations one of these days. We always think it's too early until it's too late. Have those conversations tonight. Sit down and over the dinner table, begin having, hey, what would you want for your care in case? Just have those casual conversations, maybe get all the family together and have a family discussion about what this looks like and how we can plan. So then it is done. So we've got all that documentation already put in place. Here's my contact information. If you would like to have that, feel free to reach out to me. I didn't realize until I got the slide put together, my email and my website is hard to read. I apologize for that. I can drop it in the chat if you'd like me to. Feel free to reach out to me. I live in Texas, so I know Texas state law and what that looks like, and I can speak very closely to what Texas looks like. Your state will be slightly different, but the conversations will not. They'll still be part of the full conversations, but the little details may change depending on where you're located. So, Eden, that's all I've got.
Putting everything in the chat. As always, I'm going to encourage you to save your chat. If you open your chat and you click on the three little dots, you can save it because I did put in her email address, her cell phone, as well as, although I did misspell senior living, so that's on me.
I'm going
to put that in there.
Advisors Austin. There you go.
There we go. Perfect. Thank you. So we do have some questions. I always want to ask the questions that people have actually asked, aside from, because I'm like, I always have a ton of questions myself. So somebody first did ask about conservatorship. If you could talk a little bit about that. When you were talking about legal, he asked this question. If you could maybe talk about what is a conservatorship.
Yeah, great question. I know enough. I'm not a legal expert and I cannot give legal advice. The one thing I would say to that is part of that legal conversation that you do need to have, whether or not that's the right decision for you. I always revert those conversations to a good elder care attorney. I am not proficiently versed in conservatorship, but that falls along those lines of powers of attorney, guardianship, and then conservatorship of person and of assets.
Another question we had is, obviously you're in Texas and you did talk about like you can Google to find somebody, but in another state, is there, for example, like if you're looking for an LSVT provider, you can go under LSVT Global and put in where you are. Is there something for like the geriatric care managers or the senior living advisors that people are associated with? And that, as you said, you have all this alphabet soup after your name because you care, that somebody could find someone like that. Is there something like that, or it's really just kind of word of mouth and Google?
That's a great question. People ask me that all the time, and it really, the mix of what we offer in our agency is because of my background. I've spent 20 years in the long-term care, aging, and dementia world. And so that is a mix of all of my background and expertise. And so we have offered what we are qualified and versed to do. I would start it if you're just looking at living options and you really want to look at who offers placement or referral service. A really good start would be npralliance.com or .org. Someone double check me. That is the National Placement and Referral Alliance. It is a network of folks that are incredibly talented at what they do. They know their local area, and they can be able to speak to pricing, availability, what all that looks like, particularly in your state or your locale. If you're looking more of a global, let's say a social worker, someone that really has a broad spectrum of expertise, I really would start with aginglifecare.com or .org. They are what used to be known as geriatric care managers. They have a very broad expertise. A lot of them are social workers, clinical social workers, a lot of them with MBAs that are really knowledgeable about a lot of different areas and can guide you in the right direction.
And then since you did bring up facilities, somebody was asking if elder care facilities require one to be of a certain level of health. For example, if you had Parkinson's, would that limit where you can apply? Or is that just, it's not that the diagnosis is, they're going to, I mean, I would like to think no assisted living, for example, would say you've got Parkinson's, we don't want you, but there would be that assumption of you have to be able to complete certain things on your own to qualify for an assisted living versus independent or nursing or something.
So that's a great question. I will say here in the state of Texas, 55 plus apartments and what we consider independent living, those fall under fair housing. They cannot exclude you for any reason whatsoever. If you can afford to pay the rent, you can appear to either bring the care to you if you need it, then absolutely that could be a good fit. When we begin looking at assisted living and dementia care, that is licensed under the state. Each state has different verbiage or different laws and regulations, standards by which they follow. That let me thread this needle very carefully. Oftentimes, Parkinson's medications, everybody knows, and I can probably see a ton of heads nod, with DOPA drugs, they need to be administered as prescribed on time. The state of Texas dictates that a medication technician or a community which offers care has 1 hour prior and 1 hour following that prescribed time. And I go to bat for my people every single day. There are communities that do this really well, and spot on are they at 8, 12, 4, and 8. And then other times you may not get it until 9 o'clock in the morning, but you may get it at 11 before lunch. That doesn't work with our DOPA drugs. And so in a nutshell, yes, there are some communities that will exclude based upon a Parkinson's diagnosis. And it's not because of the diagnosis per se, it's because of the stringency of the way the medications must be dosed. Does that make sense?
Thank you. So now I want to go back to, you started with A, acknowledge or ask. And I kind of want to break it down for people because I do feel like if people think like I have to come up with a whole plan in one day, I think about it in terms of like if you were organizing your house, you would start with a drawer. And so I was kind of thinking like, how might you consider breaking it down? Is there a good way to kind of start the conversation? Are there things you're like, the first thing you really do want to discuss is this, you know, and like start here and then, you know, go down, you know, because I just like I could see that for me, you know, my first thought would be, okay, I want my organs donated, and I'm like, but that's a little higher level. And given what I do, I've thought a lot about this. This isn't an off the cuff thing, and I've had these conversations. But I know not everyone is in that situation, and so I kind of want like, how, you know, how do we start? How do we get this going? How do we do the ask and the acknowledge?
Simply knowing that a whole bunch of conversations need to happen. I see some families that they're scattered all over the United States. We hop on a Zoom call. We've got all 5 children. We've got mom and dad. We've got everybody in one place, and we go bit by bit. We just start ticking it off and having those conversations, no particular order, but we're having the conversations and maybe starting the conversation. This is to be a discussion that is followed up on later. But we start the conversation knowing that a few of these items need to be discussed. We can always discuss it at another time, come back together and continue the discussion. There is no particular order. You discuss it as you feel that you can, that you want to. Maybe you've identified a need that is the greatest. Let's put our legal documents in order first. Or I need to know who my tribe is around me, that I need to know, hey, I can count on you for this and that. So then begin documenting that. It doesn't all have to be done at once. When I have these conversations, we just start wherever they want to start, but we hit all of the items. So if that is helpful, it's like you said, you start with a closet. You start cleaning out a closet, and then it gets into the living room, and then the kitchen and the pantry, and then you start doing the under the bathroom cabinet, and it just all becomes this, but you've opened every single door in the house. So you start the conversation is all you do. It could take months to go through all those conversations.
Talk about just keeping it all written down kind of succinctly in just a regular notebook, nothing special, just here's what I mean, because I especially like the tribe, because that to me is so important. Who is going to be there to support you if you need a ride, if you need this, if you need that? And that's something I really encourage people to do, because part of the reason I love this kind of a discussion is one, Sarah talked about, it's better to make these decisions when we're calm versus when it's chaos, it's panic, and it's an emergency. And that's really the whole point of this is, again, nobody wants to maybe have these discussions, but they need to be had. And, that's kind of where Sarah's here. She's like, hey, let's have this discussion. Let's open this up because it's just so important.
Mm-hmm.
I'm sure you get that a lot because, it's people don't want to clean out their closets. So
I usually get started with spring cleaning, and then it involves just one item, and then lo and behold, it involves the entire house. So those are these types of conversations. You're going to hit on all of them, but it may take you that 3 hours while I'm there. It may take you a year to get through all of those items, but at least you've discussed it and people know our wants and wishes.
Now we have a question. How can you anticipate placement if someone is functionally independently at home with help? And I would say it's not so much that people anticipate the placement, but it's about planning for it.
It is. An awful lot of folks ask me to, let's say, given my location, my care needs, my future care needs, what I anticipate this may look like, and my budget, what have I allotted for that type of care? Can I afford to stay at home? Here in Texas, we're looking at about $35 an hour for home care with a 4-hour minimum. Some agencies have a 12-hour minimum. So if we're looking at that amount of time and money that's being put forth for care to stay in our home, where does that scale tip? Usually here at $35 an hour, that scale tips at about 6 to 8 hours of care per day or more. Here in our area, right around that point, it becomes cheaper to look at a long-term care facility. And so a lot of families want to go ahead and lay eyes. There are a few of our communities that are full with a wait list. They want to explore every single one of their options. I'm going to lay eyes on all of it. I'm going to pick that one and I'm going to get on their wait list. I don't have to take it when they call me. I can say, I'll pass for now, keep me on the wait list, call me with the next one. You can continue to do that over and over again because you know that's the one you want to go to when the time comes.
When you tour the facilities, because since you brought it up, this is again one of my favorite topics. Are there things you would recommend people look for? Like I always say, you need to taste the food, because if you're going to be living here, you got to know that the food is at least something you can tolerate. I understand that eventually the menu probably gets old, but you can't be like, this is disgusting. And what other things are you looking for?
Great question. It depends on what level of care we're looking for. So let's start with 55 plus, just an apartment complex for those that are over the age of 55. Oftentimes folks are looking at real estate. What does the apartment look like? What's the square footage? Is it in a nice neighborhood? Is it a budget that I can afford? What about the social engagement? Do they all get together in the main room at 4 o'clock every afternoon to have happy hour? Do they have a pool? Do they have weekly barbecues? Are these folks that I can see myself engaging with? That's typically what we look at when we look at 55 plus. Independent living, which has those supports of meals and transportation, social engagement, housekeeping, we begin looking at, do I like the apartment? Do I like the community? Is it in a great location? Taste the food. Is the food along the lines of I would serve or have always served in my life that I find palatable? I've had some people that say, I want fresh fruit and an avocado on my plate every single day. I have folks with cultural identities that want a certain amount of food. Let's say a vegetarian. We want a wide range of vegetables and non-meat items that I can build a plate from. I don't want to eat salad at every meal. When we begin looking at care, assisted living and dementia care, look at things beyond real estate. Yes, it's important that location is important, but we can go out of our location if care is better somewhere else. What I look for as an elder care consultant, I'm also licensed in the state of Texas as an assisted living and dementia care manager. I know the state regulations, so I'm looking at care. And how can you judge care? I'm looking at the care staff. Do they appear happy? Do they talk to me when I come down the hall? Do they engage with the residents? Are the residents clean? Anything under their fingernails? Is their hair brushed? Do they look disheveled, or do they look clean and neat and well cared for? Is the facility clean? Are the carpets 25 years old and are filthy as all get out? Do we smell urine when we walk in the front door? There's a difference between fresh urine and stale urine, and that's a certain smell. So absolutely taste the food as well. Make sure that it's something that you would rather have. Do they serve hot dogs and tater tots at every meal? Or are they serving a wide range of nutritious meals? And would they cater? Here's an important one. Would they cater to a gluten-free diet or a dairy-free diet, a sugar-free diet, a low-salt diet? What happens at a certain point where I have difficulty with swallowing? Will they modify my food choices? Will they do a mechanical chop? Will they do thickened liquids? At what point is it beyond their capabilities? And we need to ask all those questions. Diabetic care is incredibly important as well. When we begin looking at assisted living and dementia care, we really need to look at care and medical diagnoses that go into that. Insulin dependent diabetics, not all communities will do this or can do this. That's a very gray line here in Texas. Dopa drugs. Are they going to be administered at the time prescribed, and can I count on that? Even if we are in that window of an hour before, an hour after, can we tighten that to 30 minutes before or 15 minutes before or after? So those are questions to be had. When we begin looking at dementia care, we begin looking at what is the training of their staff. Do they use positive approach techniques? Do they all they want to talk about are behaviors and medications? Run. Absolutely run. Get up and walk out. Behaviors is an expressive communication. It is a way of saying, I don't like that. It is a way of saying, for one reason or another, that doesn't feel good. I have a soft spot for those folks that maybe can't express their wants and wishes. And we're seeing that in some semblance of what we call a behavior, in which if we know how to be a good detective, we can give better care. We are giving care with, not for. So there's my soapbox for today.
No, I like this. This is great information because I feel like people don't recognize this. And again, this is uncharted territory for some people. And then that makes it scary, which then makes them hesitant to do it because it's just, oh, this is a chore. Or it's not so much that it's a chore, it's that I don't necessarily know where to start. And
or
you know,
even what to ask. Yeah.
So, and then one thing you did say that I do just want you to repeat, because I feel like people don't realize this. You can get on a waiting list and they will just call and say, hey, we have a room available, and you can always say no. And and they can just keep doing it. But this way you at least are someplace you want to be, and kind of your ducks are in a row before they need to be in a row. So you talked about that, and I really want to drive that point home.
Yes. Yeah. Linda put in the chat box something that I grabbed out of the corner of my eye about a trust when it comes to Medicaid planning. Here in the state of Texas, we oftentimes call those what's called a qualifying income trust, or a QIT, or what's called a Miller's trust. Absolutely. There is a cap for Medicaid here in Texas. It's $27.42. So below that, absolutely financially qualify, but you've still got to medically qualify for Medicaid. So $27.42 is that cap. Anything above, I would speak with an elder care attorney about getting a QIT or a Miller's trust to be able to bring that down. Oftentimes we fall in that donut hole. We make too much money to qualify for Medicaid, but we don't make enough money to pay for our care. So that's where that legal advice comes into play.
One thing I am curious about, what happens if you don't have friends or family to make decisions for you? What can people do? We do have a whole flying solo support group. So that is something I'm very aware of, that not everybody has a fiance waiting outside to, maybe give an opinion. Or I remember I worked with a doctor and her parents were unfortunately in a car accident, and they had torn up their information, and she really had to make decisions. And what happens when you don't have a family member to do these things?
Yeah. And we're seeing that more and more, especially with the boomer generation. We're seeing that a lot. Folks of divorce or fractured families. There is a terminology in the industry, like it or not, I'm going to throw it out there. It's called an elder orphan. We have no one in our life to make those decisions. So oftentimes we discuss, let's say, a friend, a parishioner at church, someone that we feel a connection to, that we will go into a legally binding power of attorney that they are acting on our behalf. If you have no one and there is not anyone that will step up, or you feel comfortable in asking, that's where the aging life care professionals come into play. You can hire those folks to act as your advocate. I would highly suggest you put your wants and wishes down on paper. You document what you would like, and then you share that with them, and they will make sure that those wants and wishes, as much as possible, are honored.
Anybody have any other questions? because I can ask questions all day. Given this is a topic that is very near and dear to my heart, because it is important to have your wishes honored, to have people know this is what I would want and this is important to me. And so I just, I'm so excited Sarah could come today, because she's talking about a topic that I absolutely love. And I feel it doesn't get discussed enough. And I certainly understand the hesitancy. I can remember having the conversation with my parents, and I at least can say, well, because of what I do, you know, I think we need to have this discussion, versus saying, hey, you guys are getting old, we should talk about this. That's not really a good way to start a conversation. But I just think that you really do want to start planning. And, you know, I think that Sarah just gave some great points as to things to focus on. But definitely to get started, and to also realize this is not a one and done conversation. This is going to be multiple conversations. So kind of plan it accordingly. Don't expect, you know, Rome was not built in a day, and we're not going to have this all figured out. But even if you said, I will have X amount of 20-minute conversations, or I will spend 15 minutes writing down these thoughts of what I would want, that we will share that. Because again, it's writing it down is great, but then this person has to frantically go through a journal. You do want it to be shared and somewhat organized, and have somebody know what's going on.
There are numerous documents or guidelines or books that are out on the internet, that if you will search for some semblance of a caregiver book, or how to document your wants and wishes, some of those will lead you to advance directives. But there are numerous items or booklets that you can print off, or some are even in electronic form that you can fill out online and then print. I would highly advise you to have that, and your financial documents, your legal documents, all of that put together. Get a 3-ring binder, put all of that together, and have that readily accessible in case you need it.
Thank you so much, Sarah. This was so wonderful. This was recorded, so this will be available tomorrow, and Sarah has generously agreed to share her slides. Again, I remind you to please save your chat. We put some links in there, and we have a tradition here at PMD Alliance, our wave of gratitude. Thank you so much, Sarah, for giving us your time today and sharing your knowledge with us. I appreciate it.
You're so welcome. Thank you for having me.
Have a wonderful day, everyone.